Hello, everyone, and welcome to today's live broadcast, Psychiatric Pharmacogenomics, Practical Applications for the Community Psychiatrist, presented by Dr. Joachim Benitez, Clinical Psychiatrist, Watson Clinic, LLP. I'm Christy Jewell of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots, the leading scientific social networking website and provider of virtual events and webinars, advancing scientific collaboration and learning. Now let's get started. I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We will answer as many questions as we have time for at the end of the presentation. If you have any trouble seeing or hearing the presentation, click the Support tab down at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education, ACCME, through the joint providership of Global Education Group and Labroots. Global designates this live activity for a maximum of 1 AMA-PRA Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in the activity. In order to receive credit, participants must view the entire webinar and then complete both the evaluation and post-test, at which time they will be sent a certificate via email. I would now like to present today's speaker, Dr. Joachim Benitez. Dr. Benitez is on staff at the Watson Clinic, serving as a community psychiatrist in Lakeland, Florida. He was formerly a dual appointee, working as an assistant clinical professor at Weill-Cornell University and at Columbia University in New York City. As part of the attending teaching staff, he was charged with the education of residents and medical students and the formation and training of future thought leaders in the field. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Benitez, you may now begin your presentation.
A pleasant day to all. I'm glad that you have joined us today for this talk. This talk is entitled Psychiatric Pharmacogenomics, Practical Applications for the Community Psychiatrist. As stated in the title, my target audience would be the typical community psychiatrist like myself, as I practice in a busy community psychiatrist seeing patients from 9 to 5 doing psychopharmacology work. Allow me to introduce myself. I am Dr. Joachim Benitez. I am on staff at the Watson Clinic limited liability practice in Lakeland, Florida, where I serve as a community psychiatrist and a quasi-partner on staff seeing, on average, 16 patients a day. Prior to that, I served on staff at the New York Presbyterian University Hospital of Columbia and Cornell, where I held dual appointment as assistant clinical professor at Weill-Cornell University and at Columbia University. As part of the attending teaching staff, I was charged with the education of residents and medical students. I was also involved in research and writing, primarily in psychiatric pharmacogenomics. My academic pursuits have followed me since my residency training at the Mayo Clinic, where I became involved early on in pharmacogenomics and their unique clinical applications under the mentorship of Dr. David Mrazek, former chair of psychiatry at the Mayo Clinic and one of the fathers of psychiatric pharmacogenomics. I've had over a decade of experience using pharmacogenomic tests, providing patients with individualized and personalized medicine, delivering care using the guiding principle of giving each and every patient the right drug at the right dose at the right time. I have had extensive experience working with very complicated treatment-resistant psychiatric outpatient referrals, having spent several years at the Payne Whitney Partial Hospital program in Manhattan, And now I've taken this approach with me to my outpatient practice in Florida, where I see a broader spectrum of community patients. For my disclosures, I have no relevant commercial interest. And now, what will I be talking about today? In a nutshell, I'll be describing how the community psychiatrist is actually at the vanguard of the psychiatric pharmacogenomic practice in our nation. As it is, these practitioners who provide care to the patients where it is most needed. It is in this scenario where we see the day-to-day struggle of the everyday patient who encounters treatment resistance or a plethora of side effects which may curtail the desire of the average patient, already stigmatized by society because of their mental illness, from seeking proper psychiatric care. Psychiatric pharmacogenomics is a tool in the armamentarium of the community psychiatrist to cut through that treatment resistance, limit side effects, and ultimately improve outcomes for patients in the community who experience unnecessary hardships brought about by their oft difficult to treat conditions. Now, there are certain genes and genotypes which we will review that are relevant to test for patients with psychiatric issues. There are practical applications for these tests which can be justifiably utilized after repeated treatment failure or experiencing vicious side effects, and in some cases, even prior to embarking on a medication trial. And finally, there are basic resources on pharmacogenomic drug information that a well-informed psychiatrist should be aware of when prescribing psychotropics that can guide treatment in the present and moving forward. Now let me lay the groundwork for the argument. Major depressive disorder is associated with significant clinical and economic burden worldwide. In the United States alone, we experience a 16.6% lifetime prevalence rate. Most guidelines recommend antidepressants in conjunction with evidence-based psychotherapeutic treatment options as our first-line approaches to care. Unfortunately, not all individuals will respond to initial treatment. Many will fail. This subsequently results in trial and error or heuristic approach to prescribing, which has become part and parcel of everyday clinical practice. While a blend of communication, common sense, experience, and clinical acumen optimizes the subsequent patient experience, limiting factors such as situational stress, trauma, entrenched personality styles, and substance use often limit the likelihood of adequate outcomes with accepted therapy. In the sequence treatment alternatives to relieve depression, or as everyone knows it as STAR-D trials, the rate of response to initial antidepressant was only 49.6%. This is a typical situation in outpatient scenarios to have patients fail their first stab at an antidepressant half the time, with many patients experiencing disillusionment with care. Some choosing to try a second medication or a third through the usual trial and error heuristic. Others choosing to drop out of care because of the aforementioned frustration or a lack of faith in treatment. Moreover, annual medical costs for managing a patient unresponsive to treatment was nearly $10,000 more than those for a treatment unresponsive patient in 2012. Adjusting for cost of inflation, this figure would be closer to $11,500 in 2020, projecting for an average of 1.77% inflation rate. I'm going to talk about my personal experiences. And I want you folks to listen to me. In my clinical experience, I've seen a lot of these patients come in deathly afraid of trying a medication for the very first time. Some for very personal reasons, including, I'm sure some of you have seen this as well. They say, "Doctor, I want to, quote unquote, get better on my own," close quote. Or some of them say, "Doctor, I don't want to rely on a medication. I want to do it myself." Others tell me they're fine with taking medications that affect their body, such as meds like metformin, because it's fine. They take it for their diabetes. Or they might say, "Doctor, I'm okay taking lisinopril for my hypertension." But then they express great trepidation when they have to take a medication like fluoxetine because it'll affect my mind, or it might affect the way I think. Others refuse medications for religious reasons and say, "Oh, it's against what God might tell me. I shouldn't take a medication because God tells me I should not take it." And then it takes me a while to get them to accept these medications for their failing mental health. I find consults with me often seen as a court of last resort, with patients stating they would rather see any other doctor or practitioner other than a mental health provider. It is these patients that I worry the most about failing treatment over and over again. To begin with, they are already typically ambivalent or dubious about the visit. We often get only one shot to make a good impression. Consider the cost of repeated failure for these patients, emotionally and psychologically. When we continue to go on using our patented trial and error heuristic approach to treatment, as the one adult psychiatrist at my clinic managing the psychiatric needs of a county that is over 700,000 strong, and that's Polk County, drawing from a referral base of my clinic where the primary care providers, advanced specialists, physician's assistants, and nurse practitioners more than likely have already tried not just one, two, sometimes even three different psychotropics on these unfortunate patients. The cost of repeated failure in treatment is so staggering. I sometimes find it a miracle that these patients continue to come back for more treatments after repeated failures. Whew. Now, this is where psychiatric pharmacogenomics comes in. It is a handy tool in the armamentarium of the community psychiatrist to cut through that treatment resistance, limit further burden of side effects, and ultimately improve outcomes for patients in the community who experience unnecessary hardships brought about by treatment resistance. A caveat: pharmacogenomics is no substitute for an excellent history and exam. Many a patient that I've seen referred to me who had failed multiple medication trials for depression actually had a different diagnosis altogether, requiring a different approach to management. I'm sure that other community psychiatrists in our audience have seen this time and again when they have had to discontinue a patient's California rocket fuel combo, venlafaxine and mirtazapine, upon realizing that the patient had 3 first-degree relatives with a history of mania. The patient herself exhibited hypomanic symptoms on at least 3 separate occasions in the past. Another example would be the patient failing bupropion, 450 milligrams, because of anxiety. This person probably could have benefited from an SSRI instead. Pharmacogenomics have evolved early in the first 21st century. The first generation of pharmacogenetic implements were created by Roche Laboratories around 2004, when the cytochrome P2D6 and cytochrome P2C19 were made available. cytochrome P3A4 and pharmacokinetic information also became available, as well as SLC6A4 pharmacodynamic gene. These first-generation tools provided genotype and phenotype accounting for pharmacokinetic and pharmacodynamic information. However, they did not provide information regarding combinatorial synergies between variants of genes, nor did they offer clinical interpretation. They also did not offer recommendations or flag drug-drug interactions. Looking back, I started my residency at the Mayo Clinic in Rochester, Minnesota in 2004. At the time, our department chair was Dr. David Mrazek. He was a forward-thinking academician, clinician, researcher, and mentor, and determined at the time to ensure that his residents, including me, were well aware that the bio and biopsychosocial approaches to care involved thinking about how pharmacogenomics played a role in patient response to care. Back then, we were encouraged to use the available technologies when feasible for our patients, including the aforementioned P2D6, 2C19, P3A4, and SLC6A4 on suboptimally responding patients. We sometimes even tested for HLA-B15012 on Southeast Asians prior to starting carbamazepine, as 15% may develop Stevens-Johnson rash if the genotype was present. Back then, however, residents and attendings were left to interpret the results on their own. This was a first-generation and classic approach where each test was ordered individually according to need. And as clinicians, we arrived at our own conclusions independent of laboratory support. The tests back then, as I recall, were much more expensive and ordered primarily for patients who we saw on the inpatient medical service, through consultation liaison, or at the inpatient psychiatric unit, where the cost of the test could be lumped into the cost of their inpatient stay or as a super bill. It was only years later that the second generation tools utilizing combinatorial or polygene testing approaches that this thing finally came into prominence. The combinatorial or polygene approach was based on evidence that most antidepressants interacted with multiple pharmacodynamic and pharmacokinetic pathways accounting for synergies between genes included in their testing panels, and providing drug-drug interactions that inform the drug selection and dosing decisions. It also helped that combining these tests in packaged products rather than individual tests, that costs were significantly reduced. The test also gradually became more affordable and accessible to clinicians as time went on, but still, it made more sense to order these tests as a bundle from third-party testing companies for the savings it would entail rather than as individual tests. Despite this, these tests varied considerably, with each test kit being subject to its proprietary decision algorithm, which in turn led to a unique report available to the patient. The individual pharmacogenetics presented may not have varied considerably, but the interpretive results, based on weighed combinatorial relational gene-gene, drug-gene, drug-drug, or environmental interactions, might have influenced a recommendation one way or another. At this time, most of the drug testing being done in the United States, from my experience, this is not a very popular technology elsewhere in the world. I've had opportunities to liaise with patients and peers internationally in my career, providing expert care for treatment-resistant depression in my work at Payne Whitney with Cornell and at Columbia University, as well as when I was doing expert second opinion work for international patients with a Barcelona-based group called Advanced Medical. And I think this has to do with availability in the United States for insurance coverage for these testing services, as well as other economic factors that come into play. Chad Boseman, in his Lancet article in 2016, pointed out that there were 19 options for clinicians to choose from in the United States, as opposed to 3 in Canada, 3 in Europe, 3 in Asia, 2 in Latin America, 2 in Oceania, 1 in the Indian subcontinent. A glaring disparity in availability of coverage. There is less support for direct-to-consumer genetic testing, as 3/4 of psychiatrists believe that genetic counseling would be necessary for patients receiving this information. While the manufacturers and developers of pharmacogenetic tests advocate for preemptive use of their tools, argue that these tools are more likely to be beneficial to the patients if used prior to the usual trial and error heuristic to treatment, the standard of practice remains to order these tests in a reactive fashion. Once the patient has failed or has shown sensitivity to several medications, we can make an argument for the safety of special populations, such as the HLA-B15012 testing on Southeast Asians prior to starting carbamazepine, but this is sometimes a hard sell when you are dealing with insurance companies. In this day and age, when many labs no longer carry individual tests as they are too expensive and have to send them out to places like the Mayo Clinic, and the most cost-effective alternative is the bundled test, the onus is often on the psychiatrist and the patient to provide evidence through documentation of treatment resistance or treatment failure prior to insurance coverage, or for the patient to make a decision to cover the test out of pocket himself or herself. A shameless plug. The last paper I wrote before I left Cornell was how insurance companies can come up net even and even avoid spending more money on their panels of depressed, anxious, and bipolar patients by doing preemptive pharmacogenomic testing on their treatment-naive patients, short-circuiting a boatload of frustration, grief to the patients, and saving these insurance companies money down the road, as the patients on their panel are less subject to morbidity via clinic visits and hospitalization. Here is a reference to that study. A number of retrospective trials have assessed the health resource utilization and potential cost savings for patients with the use of genetic reports. In a retrospective review, Chow in 2000 found that among patients on cytochrome P2D6 dependent medications, those with poor or ultra-rapid cytochrome P2D6 metabolism spent between $4,000 and $6,000 more in 1 year period. Ruano in 2013 retrospectively found that individuals with reduced cytochrome P2D6 function average hospitalization length of stay that was 2 days longer than those with normal or increased cytochrome P2D6 function. In another study, a retrospective chart review, patients that were on medications predicted to yield the greatest gene drug complications presented with significantly increased total healthcare visits, medical absence days, and disability claims, resulting in nearly 5,200 greater healthcare expenditures than those on genetically appropriate medications. That was a Joel Winner study in 2013. Another study, which was a larger scale analysis of health claims data, that was the one done by Fagerness, showed adherence rates and medication costs using multigenic, though not combinatorial, report showing that patients provided with genetic testing were significantly more adherent to their medications compared to standard of care. And that was the Fagerness study done in 2014. Based on the aforementioned studies, we can show how pharmacogenomics adds value from a fiscal standpoint to psychiatric practice and does not detract fiscally. There are certain genes and genotypes which we will review that are relevant to test for patients with psychiatric issues. As I had mentioned, safe and effective medications are one of the greatest challenges in psychiatry. Large prospective clinical trials provide evidence for these challenges, with increasing poor response rates and intolerance of treatment after a patient fails one medication, which are exacerbated with each subsequent medication failure. Pharmacogenomics utilizes genetic information to predict responses to medications on a personalized level on known gene-drug interactions for both pharmacokinetic and pharmacodynamic genes. Pharmacokinetic response to neuropsychiatric medications is largely driven by the cytochrome P450 enzymes expressed in the liver. Metabolism of medications by these enzymes affects the drug levels in the blood, which will ultimately result in potential for efficacy and/or side effects. An individual may be a non-expressor, poor metabolizer, a normal metabolizer, a rapid metabolizer, or an ultra-rapid metabolizer. For example, an individual can be a poor metabolizer for a drug, which will result in high drug levels and increase the potential for side effects. Conversely, a patient who might be a rapid metabolizer might suffer from poor response to treatment due to suboptimal dosing. Examples of pharmacokinetic genes and their substrates include cytochrome P450 2D6, the following here: fluoxetine, venlafaxine, nortriptyline, etc. Cytochrome P2C19, citalopram, escitalopram, amitriptyline, and the following: cytochrome P3A4, aripiprazole, brexpiprazole, iloperidone, etc. Cytochrome P2B6, bupropion is the classic. Cytochrome P1A2, clozapine, olanzapine, chlorpromazine, and duloxetine. Pharmacodynamic genes predict response to a medication at the site of action. As an example, the serotonin transporter is encoded by SLC6A4 and has two main allelic variations, S and L. Patients with an SS genotype have reduced rates of remission and response with selective serotonin reuptake inhibitor treatment. Conversely, patients with an LL genotype have better responses when using SSRIs. A meta-analysis of 1,435 patients with the SS allele took longer to respond and were less likely to achieve remission compared to controls. Both pharmacokinetic and pharmacodynamic genetic differences contribute to the variability of response and potential for side effects for a patient. Select medications are exclusively metabolized by a single gene and will likely only be pharmacokinetically impacted by genetic variation at that single locus. For example, cytochrome P2D6 copy number variation has been demonstrated to have a significant impact on plasma levels of nortriptyline, which is exclusively metabolized by cytochrome P2D6. However, the majority of medications are metabolized by multiple enzymes and can have considerable variability in receptor and transporter binding profiles. When faced with this complexity, it is now the psychiatrist's decision whether they want to go with a testing company that provides a lot of clean information from single gene tests, much in the vein of the classic testing paradigm, or if they want the testing company to do the interpretation for them by synchronously evaluating the combination of pharmacokinetic, pharmacodynamic, or pharmacodynamic gene interactions for the individual in question. A classic conundrum for testing, the SSRI citalopram. This drug is metabolized by 3 different enzymes: cytochrome P2C19, cytochrome P2D6, and cytochrome P3A4. The main weight is carried by cytochrome 2C19, however, with the 2 being secondary. Additionally, the serotonin transporter SLC6A4 is the pharmacodynamic site of action. Identifying genotypic differences concomitantly for these 4 genes may lead to composite phenotype for citalopram in one's mind and yield the most accurate, clinically actionable information. For example, the patient may have rapid metabolism for 2C19, slow metabolism for both 3A4 and 2D6, but have L/L as your SLC6A4 genotype. As I was thinking about it, a combinatorial testing outfit might warn you against starting citalopram. But if I had seen each gene individually tested, noted that the patient was a young adult with no heart problems, a mother and a brother who both did well on citalopram, failed fluoxetine and bupropion previously and wanted to try this medication, I could very well have sold myself on the idea of starting this patient on citalopram based on what I already knew about the component information regarding each of the pharmacokinetic variables dictating citalopram metabolism and the pharmacodynamic principle regarding citalopram SSRI action. To reiterate, one can either choose to go with a testing company that gives you component parts to assemble, or other testing companies that provide proprietary combinatorial algorithms which purport to give you the best possible option given the patient's myriad genotypic variations. The choice, I believe, resides in a clinician's level of comfort with these tests. There are no right or wrong answers. As a rule of thumb, when the need arises, I tend to order the test that my patient's insurance company will cover. I'm generally pleased with the information I get with most testing companies out there. Again, it's really what tests you can get for the patients affordably and what you can make of the information that counts. At the end of the day, how you can make clinical sense of the data, use it to the patient's best advantage, and interpret this information to aid the patient's recovery and welfare is all that really matters. After all, the test is nothing more than a tool. It's of no use to you or the patient if you don't understand what it is you're looking for or why it is you're looking for that information in the first place. Practical applications. As I had mentioned, there are practical applications for these tests which can be justifiably utilized after repeated treatment failure or experiencing a vicious side effect. And in some cases, even prior to embarking on a medication trial. Preemptive testing is not likely unless the patient has very deep pockets or the best available insurance. The most likely scenario is that these tests are ordered after several repeated or failed trials of a medication. Even justifying a test preemptively for carbamazepine on Southeast Asians prior to starting it might not be justifiable anymore, as it is not the first line of medication we use for bipolar conditions. The gold standard remains Depakote and lithium, so most patients usually try both Depakote and lithium in the first place and fail these medications, so the notion of preemptive testing is likely obviated. Most patients anyway would have failed some medication previously, would have justified some drug sensitivity or side effect, which would allow one to order some other test previously. So it renders these things moot and not helpful. There will come a time when you will encounter a patient who will want to have these pharmacogenetic tests done. This may be some patient who has caught wind of genetic testing through a friend of theirs who had this done elsewhere, or a family member who had success through care from a different provider, courtesy of genetic testing, or had seen some commercials of direct-to-consumer genetic tests and have conflated these tests with the clinical grade tests that we can provide them. It's our job to differentiate these tests from the ones that they obtain as direct consumer tests. These tests do not provide the wealth of clinical data that can be obtained from pharmacogenetic testing and are not anywhere near as clinically relevant to their purposes. In my experience, I've had some patients come to my office with their direct-to-consumer tests with reams of papers, binders of information, hoping they can make sense of what they have, thinking that I can unlock the information contained there to help them unravel the mystery behind their secret lives, their past histories. Unfortunately, much to their chagrin and dismay, they're left wanting and disappointed. I don't think we should chastise or blame these patients for the misinformation that they've received. Rather, we should provide them with support and counsel. They come for care and good evidence-based medicine, and we should provide them with that. The tests are primarily used by community psychiatrists for major depressive disorder. However, as psychiatrists, most cases we see in the community are never really that clean. As some cases we see have multiple comorbidities. Some of these tests also have applications for ADHD, anxiety, bipolar, schizophrenia, and pain. There are other tests that offer a plethora of pharmacogenomic information beyond that which the typical psychiatrist usually need. Test reports can extend to multi-system treatises on how the patient's pharmacogenomic profile impacts not just their psychiatric health, but also other systems from neurology to cardiology to urology, oncology, endocrinology, GI, immunology, and beyond. Again, this depends on the test company one orders from and the sort of level of sophistication and complexity one wants from the test. As another rule of thumb, order the test from the company that you feel will suit your patient's needs best. Now, I will talk about resources for the community psychiatrist. There are basic resources on pharmacogenomic drug information that a well-informed psychiatrist should be aware of when prescribing psychotropics that can guide treatment in the present and moving forward. It is very, very easy to get lost out there, as there is a sea of information regarding drug-drug interactions, drug-gene interactions, drug-environment interactions, drug-food interactions, and drug-alcohol interactions. If you want to educate yourself, make sure you have a number of resources available at your desktop and readily accessible when you need it, so as not to be fumbling when the moment arises. Given the wealth of information out there and the infinite number of permutations one might see on any given day while working with patients, it does not seem feasible to commit everything to memory. The best strategy, it would seem, is to start slow and build one's mental database brick by brick until one is confident with enough information to detect patterns and relationships between certain medications and drug classes that influence each other. For starters, one will want to be able to access good pharmacogenomic information readily available so as not to get lost when the moment comes and the decision to make a med change arrives. A really good online source is the Indiana University Department of Medicine Clinical Pharmacology table. I've been referring to this table since I started residency back in 2004. It now goes by the name of the Flockhart table, probably after some wealthy donor. 15 years onward and it is still going strong. It's a veritable classic. If you choose not to order any genetic testing, at least make sure you're aware of this and the information contained herein. This will certainly help you navigate the often complicated world of interactions between drug substrates, inducers, and inhibitors that we see in our practice daily. I can also give you many examples of how this can come to play, but here is one scenario. I'm sorry that this slide is blurred, but this is the best image I could pull online. A patient was being treated with citalopram and bupropion initially for depression. When he didn't respond, was switched to fluoxetine and bupropion, then went to me for consult. He was not doing well, was feeling ill and lethargic on initial visit. What did you think the issue was? I wasn't sure, but I wasn't going to wait for a serotonin syndrome or seizure, nor was I going to wait for genetic testing to be done. I went straight away to get my Flockhart chart. The Flockhart chart showed me that both bupropion and fluoxetine inhibited 2D6 fivefold, and fluoxetine was mainly metabolized by 2D6. I could have ordered pharmacogenomic testing, but that would have taken too long for results to come. I may have found him to be a slow metabolizer of 2D6, and that would have been helpful, but either way, this was something I decided to act on independent of testing, and I decided to stop medication. The testing would have given me an extra layer of information, and it would have been helpful, but I decided to act anyway. Another good online source of information is the PharmGKB website. This website is terrific. It is an NIH-funded resource that provides information about how our human genetic variation affects response to medications. They collect, curate, and disseminate knowledge about clinically actionable gene-drug associations and genotype-phenotype relationships. On this website, they have information on individual genes, drugs, and drug dosing guidelines, all of which come very handy. This is the best and latest in evidence-based practice. Another useful resource is the Clinical Pharmacogenetics Implementation Consortium Drug Dosing Guidelines. The Clinical Pharmacogenetics Implementation Consortium, or CPIC for short, is an international consortium of individual volunteers and a small dedicated staff who are interested in facilitating use of pharmacogenetic tests for patient care. A barrier for implementation of pharmacogenetic testing in the clinic is the difficulty of translating genetic laboratory tests to actionable prescribing decisions for affected drugs. Their goal to address this barrier is by posting freely available peer-reviewed, evidence-based, updatable, and detailed gene-drug clinical practice guidelines. They seek to use systematized grading of evidence and clinical recommendations using standardized terminology, using peer reviews, publish it in leading journals, and post it on their website where it's regularly updated. The CPIC has key guidelines to a bunch of things. Pertinent to psychiatry are the CYP2D6 variations of atomoxetine, HLA variations of carbamazepine, the CYP2D6 and CYP2C19 variations of several tricyclics, including amitriptyline, clomipramine, desipramine, imipramine, trimipramine, and the same variations of several SSRIs, including escitalopram, fluvoxamine, sertraline, and paroxetine. Now, why is this pertinent? Because this is the self-same information that you will find on the FDA drug labels of the aforementioned drugs, particularly in this section when they discuss the pharmacogenetics of these drugs and how these variances may affect response to dosing. These guidelines rise to the sort of scientific scrutiny that one would be remiss not to know. If you neglect this information, beware. To conclude, I think we all now understand how important the community psychiatry is, being at the point of the spear of the psychiatric pharmacogenomics movement that is in play in our nation. There are more and more patients each day who avail of these tests, and it is these practitioners in the community who provide care to the patients who use these tests the most. It is also these practitioners in these scenarios who encounter the patients with the greatest levels of treatment resistance and side effects. They are the bastion of hope and the main bulwark against the community stigma in psychiatric care. We discover that psychiatric pharmacogenomics can be a tool in the armamentarium of the community psychiatrist to cut through that treatment resistance, limit side effects, and ultimately improve outcomes for patients in the community who experience unnecessary hardships brought about by their oft difficult to treat conditions if used wisely. Of course, as I had mentioned, there are limits to implementation. We learned that certain genes and genotypes were relevant to test, and there were basic resources on pharmacogenomics and drug prescribing information that are useful. To end, I would like to thank my colleagues at Labroots for organizing this and arranging the logistics and for making this CME possible. With that, I thank you. Have a good day and take care. I would like now to open the floor for questions.
Dr. Benitez, thank you for that informative presentation. It is now time for the live Q&A. If you do have a question you'd like to ask Dr. Benitez, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we will answer as many questions as we have time for. Okay, Dr. Benitez, our first question is, what sort of qualities do you look for in a pharmacogenetic test?
Christy, I'll reveal my biases here. coming from an old school first generation approach where we used to do all these tests individually rather than how it's done presently. I'd much rather go with testing where I get a wealth of information, obtaining lots of genes from the patient, leaving me with the freedom to interpret the information on my own afterwards, rather than going with tests that force me to think along the lines of second generation combinatorial strategies, which, although may be helpful if one is in a time crunch, may be ultimately limiting if one actually wants to know what is truly going on with a patient. I honestly can't make any specific recommendations about which tests one can get in the market, of course, because of the nature of this CME, but one should look to find tests which will allow one to mine a plethora of genetic information for their patients and be as learned as possible about these genes to take the best advantage of the available information that one can mine.
Thank you, Dr. Benitez. Now let's go with this question, and it's come in a few times here. What do you think of tests like 23andMe and Ancestry?
Those are very interesting and fun direct-to-consumer tests. In fact, my sister got one for herself and wanted me to take one myself. I told her, thanks, sis, but no thanks. They are very popular in this day and age, but they do not give you the necessary information to help you. If a patient asks you if it is going to be helpful for them, and from a clinical standpoint particularly, tell them to refrain from getting one. It is not going to be helpful to them, and it won't help them make clinical decisions related to care. It might help them if they want to make pop quiz decisions or to get information about their ancestry and stuff along those lines, but I would not use that to make informed clinical decisions.
Thank you, Dr. Benitez. Now we're almost out of time. We'll wrap with this final question. Why have insurers or managed care companies been reluctant to pay for these tests?
Well, some have not. I think it boils down to dollars and cents. Ultimately, once more research and evidence can be shown, as these tests have actually been saving these companies money and helping save lives, reducing morbidity and mortality, and improving patient outcomes along the way, then these insurance companies might recognize that these tests might turn their heads and recognize that these are very good value propositions and well worth paying for. I did come up with a study at one point that showed that this was a value proposition, and several other studies were shown to have proven that, and more recognition of these tests will prove that in the future. But it's something that will happen in time ultimately.
Thank you, Dr. Benitez. Now, do you have any final comments for our audience?
Yes, actually, I'd like to direct you to my references. Here they are.
A big thank you to Dr. Joachim Benitez for his time today and his important contributions to psychiatric pharmacogenomics. I would also like to thank Labroots for hosting today's educational webcast. Before we go, I would also like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. And lastly, one important reminder, this activity has been approved for 1 AMA PRA Category 1 credit. If you are interested in obtaining CMEs for this webinar, please complete the evaluation and post-test that will appear here shortly. Thank you for joining us today, and we hope to see you again soon. Bye for now.